organising all of the aspects of the program, but she's trying to build it into a sustainable national precision medicine platform. She didn't say whether that was adult or paediatric, so I think she meant paediatric.
For now.
So she's got more than 25 years experience in genetic testing and experience in genetic testing services in both the public and the private sector. And so all of those make her an ideal speaker for today when the focus is on translational medicine and how can we translate all these new wonderful genomic advances into clinical care. Thank you, Miss.
Thank you, Kathy. And I think the operative word is trying, and we do try very hard every day. So thanks for taking time out of your busy day today to come and listen to me speak. I can see that there's quite a few people from my team in the room, so if I get anything wrong, I'm expecting some heckling from the crowd. The first question, of course, was what is precision medicine? And I'm going to talk to you about Zero Childhood Cancer Precision Medicine Program, which is a comprehensive precision medicine program for children with high-risk cancer. And I'm going to use this for the context of how we use precision medicine in paediatric oncology and how we can build this into a sustainable platform into the future and deliver it as a standard of healthcare. But first of all, why do we actually do precision medicine? I think personalised or precision medicine, as you might have heard the two terms mixed up, it's really designed to break out of that population-based, one-size-fits-all approach to models of care, to delivery of treatments. And it's about making progress to tailor the treatment to an individual patient based on their own genetic profile. So rather than this trial and error that we have from the current population-based applications, we really want to be able to say, this is what's going to work for you the first time round. So this is about the right drug for the right patient at the right time. Do you think it can get too personal? Well, that's probably a debate for another day. But I like to think that if we can work towards really being able to deliver the right treatment at the right time, we're on the right track. Let me tell you a little bit about paediatric oncology and the children who suffer cancer. So at any one time in Australia, there are more than 2,000 children and young adolescents that are being treated for cancer or at risk of relapse. And we have around about 200 children annually who will have refractory cancer or relapse, and most of these children will die of their disease. The treatment options for these high-risk patients is still limited. So whereas we have an 80% survival now for children with cancer, we're talking about the children where there are very few options, where sometimes at diagnosis the only treatment available is palliative care, and we want to be able to really improve the outcomes for these children. We also want to look at how we can improve the long-term side effects for children who do survive cancer, because more than 30% of survivors have serious life-altering health conditions. It's a vastly different landscape to adult cancers, which I'll tell you about shortly, and we have a critical need for understanding and developing more efficient, more targeted and safer therapies for the children. To do this, we need to be able to harness and integrate the novel and emerging technologies that we are so lucky to have available to us today. Now, I said to you that children's cancer is a very differing genomic landscape from adult cancers, and these are a few of the reasons why. These are two fantastic landscape papers. I encourage you all to have a look at them if you're interested. They were published in February last year. And the takeaway points are that in children, the mutation rate is 14 times lower than in adult cancers. Now, in the first instance, that tells you that we need to treat them differently. It also tells you that we need to be able to use different tests to understand how to treat them differently. More than 60% of the events are copy numbers, and structural variants. This is very different to adult cancers. The alterations are either mutation or structural. They tend not to mix together. Again, different to adults. And cancer-driving mutations are frequently single. So close to 60% of the time, it's a single cancer-driving mutation, suggesting a single event. Whereas in adult cancers, you get multiple changes, probably through environmental and various other impacts through the course of a person's life. The mutations themselves have a far greater disease specificity, and these two papers alone suggested that there are probably more than 140 putative genes specific to paediatric cancer. Only 30 to 45% being seen in adult cancers. And again, importantly, the prevalence of germline predisposition is higher than in the average population in these two papers at around about 8%, and I will come back to that. So what is Zero Childhood Cancer doing? We ran a pilot study called Target for 2 years. That was to develop all of the methods to evaluate all the technologies out there available to us, and really develop the logistics, the systems, the pipelines to be able to open a national clinical trial, which we did in September 2017. Now, the aim of this trial is to assess the feasibility and clinical utility of a diagnostic service, which encompasses tumour molecular profiling and then also laboratory preclinical biological testing in vitro drug screening and in vivo drug modelling to identify personalised therapy for children and adolescents with high-risk malignancies. Our study population is paediatric and adult patients who are under 21 and have high-risk malignancies with a less than 30% chance of survival. We will also consider young adults who may have a paediatric malignancy or have a relapsed paediatric type malignancy. And our aim was to enrol 400 patients before September 2020. Now, to do that, we have opened the trial in all 8 paediatric oncology centres around the country. The Children's Cancer Institute and the Kids Cancer Centre at Sydney Children's Hospital here in Randwick are the research and clinical leaders respectively, but we are open at all 8 centres. I think the other thing that you can see, and you may or may not be able to read all of these, but the other thing that you can see is that we have over 21 research institutes, medical research institutes, or other research institutes who are collaborating in the Zero Childhood Cancer Program. And that is both national and international. So what do we actually do when a patient is enrolled in the program? We receive, where possible, fresh viable tissue, and we perform genomic profiling, and then where we can, we perform preclinical studies, which I'll describe. But the first step, and sorry, I don't think we've got a pointer. This might work. So the first step is that we have the samples coming in. We want to be able to do some complex genomic profiling. We have a targeted gene panel, we have whole genome sequencing, and we have whole transcriptome sequencing, as well as methylation profiling. So we're looking at a very broad range of omic tests to be able to integrate the results that we have, consider what we find, take those findings to an expert panel that we call a multidisciplinary tumour board, who then will make recommendations back to the treating clinicians in a clinical research report. While all of that's happening, and then further to that, we attempt to actually perform some laboratory drug screening in high throughput, and we also attempt to establish what we call patient-derived xenografts. Patient-derived xenografts are mouse models of the child's individual tumour. And the event that we can actually establish these xenografts, we can perform drug efficacy studies on these models with drugs that are informed by potentially the molecular screening and or the in vitro drug screen that we do. If we find something there that either corroborates or adds evidence, we then report that through, again, our multidisciplinary tumour board, the expert panel, and an updated report will go to the treating clinicians. Now, the treating clinicians can then use this information to decide whether or not they will alter the treatment for their patient.
So we are asking a series of questions. This is your time to ask about the patient journey. Yep.
Thanks, Ness. What's your success rate in getting the PDX models up and running?
So the success rate is quite varied, dependent on the tumour type. So one thing that I haven't said so far is that with the types of tumours we get, because it's a less than 30% chance of survival, we have a broad range of tumour types. So we have brain tumours, bone tumours, sarcomas, neuroblastomas, high-risk ALLs, and other rare tumours. Now, it's very dependent on the type of tumour. We have a very high success rate at the moment with our sarcoma models, for example, and I think they're up at around about 80%. Is that right, Dan? Yeah, thank you. And then certainly the brain tumour models, for example, are much more difficult to establish, and they can take a very long time, but also have much lower engraftment rates. It's one of the caveats is that this is very much the research end of the translation where we really want to be able to improve the methods that are existing and improve the models that are existing to be able to use this real time.
Yep.
I had a question about the targeted sequencing that you do as well. A lot of the panels are built upon what you know from adult cancers. Are they different in all based on cancer?
Yeah,
Do panels.
That's a great question. So we started out with a panel, and it was very much adult focused because we were collaborating with Paediatric. We did add in some paediatric genes, but we have since recently elected to stop that, not do this particular panel anymore. And the reason for that is that the information that we were gaining from the whole genome and the whole transcriptome was actually more than sufficient, and we weren't missing anything by doing that and not doing the panel. What we will do, though, moving forward, is consider the development of a fit-for-purpose paediatric pan-cancer panel. And that's something that might be certainly more, I guess, tolerable and doable from a clinical implementation perspective. And all the information we have that comes from the whole genome and the whole transcriptome will drive how we design that.
David?
I'm just wondering...
You have to speak up.
You're going to do it later, and if you are, then don't pursue it now. But I'm just wondering what the transcriptome methylation has when you say that most of your tumours have a single dominant gene anyway.
I actually will cover that, yes.
Yep.
In terms of the metastases, do you find that the mutational load, which is more simplified compared to adult cancers in the primary tumour, is also simplified in the metastases? Or you're getting more mutations as they metastasize and different mutations?
So I think that's variable, and certainly the genomes do tend to be a lot quieter overall. You do see in relapsed or metastasized samples a lot of change. You will see new mutations, you'll see mutations disappear, and you will see a lot more in some of the tumours, but it's quite variable.
Okay. Yep.
In your introduction, you talked about the 30% of survivors who have ongoing serious life effects. Is your work looking at the consequences of treatment to reduce that frightening figure of 30%?
So the Sydney Children's Hospital and Kids Cancer Centre here has a late effects program, and so they do a lot of research into the child cancer survivor cohorts. That's something that they do look into. I guess the way that we contribute to that is actually trying to find safer, more effective therapies that are actually targeting just the cancer cells as opposed to the general cytotoxic chemotherapy that targets any cell that's proliferating. And the plan there then is that the overall side effects will be reduced by just targeting the cancer, but there is a very, very strong late effects program as well.
So they're looking for the, is there a genetic signature of people who are going to get lots of late effects, and then try to tailor their treatment based on that. So we had two Dorothy Dix questions, and I was expecting, David, for you to ask, is this transferable to adults? And we won't answer that one. And the next question was, is precision medicine making a difference to the patient? So we're going to use a couple of patient examples.
So thanks, Kathy. I want to introduce Ellie to you as an example of how we use precision medicine and the kind of impact that it can have on a child and the family's life. So Ellie was presented at 11 months with a very large intrathoracic mass. It was so large that within a few days she was on ventilator support in intensive care. I think some of you might have heard this story already, but bear with me. Ellie was very, very ill. She had no response to the chemotherapy, so she was resistant to the chemotherapy that would ordinarily be used in this situation. And she was enrolled on Zero's trial. And what we did with that was we performed the whole genome sequencing, we performed the whole transcriptome sequencing, and in the space of 9 days, the bioinformatics and curation team turned around the results and found an NTRK fusion, NTRK speckle1, which is actually a novel NTRK fusion. And that was really important and game-changing because it's targetable by a particular drug that's called an NTRK inhibitor. It's a kinase inhibitor, but quite different to some of the others that have been routinely used for a number of years, like imatinib, which is used for chronic myeloid leukemia. Now, larotrectinib is highly selective and very potent. And with these results, the clinicians were able to go to the company, which is Oncology, who were in the process of completing phase 1 adult trials in the US for this drug. And as a result of going to the clinicians with this information about the individual patient, about Ellie, they were able to access the drug very quickly through compassionate access, and was administered to Ellie without undue delay. So in the space of 6 weeks, she was discharged from ICU, and Loretta, was she discharged from hospital?
Yeah, no.
In that 6
Not
weeks.
in 6 weeks,
But about
another
9
6
12
weeks you went out.
So within 3 months, Ellie was home, and she celebrated her second birthday in September 2018. Now, this would not have been possible without the program that we're running and without the genomic profiling that we're conducting in the program. Now, as a result of this, we continued discussions with Oncology. And because we have the platform to do the testing here, we were able to then go ahead and open the trial in Australia for children. And that means that we are now able to enrol children on the trial without delay so that they can access this drug as soon as possible if they have one of these NTRK fusions that I'm talking about. And so this highlights an area where we really need to be able to pursue those opportunities to partner in not just pharma-led trials, but investigator-initiated trials, and really open them up here in this country so that children like Ellie and many others can access them real time. So, moving on from that, what can we do to actually harness all of this technology, all of the multi-modalities, and really make them work for us? We've had a lot of challenges to be able to do this over the last 4 years. but there have been massive benefits that have come out of that. And I just wanted to talk to you a little bit about the challenges and what we've been able to do to overcome that. So the first thing I wanted to highlight was the omics bioinformatics pipeline. When we started this, we certainly didn't have any of this pipeline available to us. We had to build it. We had a set of high-dimensional data. We had multiple types of genomic or omic alterations to consider and to integrate. And we had multiple steps in the pipeline, multiple iterations. And this took a long time to build. And while we were building it, it took us a lot longer to analyse all of the results that we had. The time, the cost, and the quality of the samples that we had was something that were constant challenges that we needed to address. And we did that with a very talented team of bioinformaticians, computational biologists, and I think some of them might be in the room. And we learned from our mistakes and we strengthened our pipelines. We were able to get some greater power out of these robust pipelines for comprehensive variant calling. And that included not just the SMVs, but it included copy number, it included structural variants like the fusion genes that I've just talked about, and loss of heterozygosity and of course germline predisposition. And so what that meant was we could now take all of these different types of genetic alterations, combine them, and really give us much greater breadth of precision recommendations possible, tailored to the individual treatments for the kids. And so that comes back to the question of how does all of this add value? Once we've done that, we're in a position where we needed to conduct collaborative curation. This is taking an enormous number of experts in multiple different locations with varied and complementary expertise, and we needed that to be able to combine the expertise of the whole genome, the RNA, the panel, and methylome. Now, is Marie in the room? Marie Wong, who's a very talented software engineer and bioinformatician, has created what we now call Lowy. And this is harnessing automated data integration using Google and Slack, and really overcoming all of the challenges that we had. Now this allows us to capture all of the discussion that is had real time between all of the individuals involved in this process. We can track the clinical decisions that are made, we can track any research opportunities that come out of it, and also use it to be able to generate the MTB, so the Multidisciplinary Tumour Board recommendations, and a clinical research report. So coming back to PRISM for a minute, and PRISM is the national clinical trial, which was the second phase of the program. And we actually have 208 patients enrolled as of today. And we had 58 patients enrolled in the target pilot feasibility study. You can see that there's a great mix of different tumour types, which I mentioned earlier, and we have close to 40% are brain tumours and close to 30% are sarcomas mainly. And there's a mix, almost 50-50, of diagnosis and relapse and progression. So coming back to how does adding in all of the different tests over and above whole genome or a targeted panel make a difference? If we had just stuck with DNA, and particularly if we just stuck with a panel, we'd only be making recommendations 30% of the time or less. Probably less if we stuck with a panel. And by adding in fusion analysis and gene expression with RNA, we can find actionable fusions. We can find copy number now with whole genome thanks to sophisticated computational and bioinformatic modelling. And we're also able to find germline mutations, which we wouldn't necessarily find in the targeted panel. So this has actually meant that if we add in all of the different types of genetic testing that we're doing, we can increase the actionable recommendations to close to 70%. Just coming back to germline for one moment, just to really focus on the fact that this is something that we need to focus on and concentrate on in terms of integration and sustainability into the future, because prevention or early intervention really is one of the keys to moving towards zero childhood cancer and zero children dying from the disease. Interestingly, well, I think it's not so interesting, but you may be interested to know that the return of reportable germline findings of cancer germline predisposition, our consent rate is 97%. So the families want to know this information and they are open to knowing this information. And I think that's a very important point to consider. We have in our national trial cohort, we have a prevalency of about 15% of predisposition mutation frequencies. And you can see that there are a few common ones there, and DNA mismatch repair signatures are quite high. And you can see that this actually correlates very well with one of the landscape papers from last February, where there is a higher prevalence of the mismatch repair signatures. And we're seeing this mostly in the central nervous system and sarcoma tumours. So how have we done with recommendations? We have completed 177 cases of molecular profiling. I'd say that's higher now because these slides were made last week or the week before. And 93% of the time there are molecular drivers that are identified. Now 71% of those are potentially targetable with drugs. There's a difference. Some mutations or drivers are actually reportable, but they're not actionable because we don't have a drug to target them yet, and P53 is one of those. That's why those two numbers are different. We've been able to make 68% of therapy recommendations in 68%. We've referred 12% of the patients to clinical genetics for germline mutations, and in 2% of the cases we actually have a change in diagnosis. And all of this we're doing from enrolment to reporting from the multidisciplinary tumour board report in an average of 9 weeks.
So questions for this part of the talk? Yeah.
Sorry, if you're not able to make a recommendation based on the genomics, what are the next steps?
That's a great question, and I'm about to answer that.
Yep.
Were there other questions?
So, with the patient Ellie, she had a great outcome. When she was diagnosed, was she treated with surgery as well? And
No.
yes, she wasn't. Okay, so just
No. Yep. And she's still doing well. Yes. So what's next? What do we do to increase our ability to make recommendations when we can't find something at a molecular level? So in early 2017, we established a preclinical drug testing core. This is led by Professor Richard Locke. I'm sure a lot of you in the audience know Richard. He is well renowned for the acute lymphoblastic leukemia models that he has developed, and so we work. He leads up this team in zero childhood cancer. The aims of this preclinical drug testing core are to combine the molecular analysis with in vitro and in vivo drug sensitivity testing for targeted and empirical drugs to make treatment recommendations, and importantly to make them in a clinically actionable time frame. Now this is a pretty big challenge that we're addressing at the moment and will do for quite some time. One of the other things that we need to do is curate publicly available and in-house data to match the right drug to the right phenotype, and our omics team and our preclinical drug testing team work hand in hand to do this. You cannot do it alone, you can't do it in silos, you must be working together at all times. Now we've got a lot of challenges that we must overcome, and nothing